This is glomus tumor. Gross picture. We can see a little bit red tumor just under the nail bed. This redness lesion tumor is really painful. Usually occurs in the distal extremity, particularly in the nail bed. Let's see the microscopic feature of the glomus tumor. So in low power, we already know that this is a well-demarcated circumscribed tumor just in the dermis, not any connection to the epidermis. And we, even in low power, we know this should be a benign lesion tumor because that is well demarcated, symmetric. When you cross the line here, left and right, it looks identical, relatively small. So, and in this power, you may see some hyaline stroma, some empty space, really highly suspicious as a blood vessel. Then let's zoom in a little bit. So we can see this bluish small cell kind of really monotonous, but they have a growth pattern just like they always try to surround this blood vessel, try to trigger surrounding them. Even when there is the vessel go out of the lesion, this cell also would like to hugging the blood vessel endothelial cells. And then higher power to convert the cytology, really round cell, every cell looks identical, monotonous, no mitotic figure, looks really bland. So when you have all of these features, you can call the diagnosis of glomus tumor. So just remember, if you see anything well circumscribed in the dermis, try to hugging around the vessel, the cell is monotonous, really highly suspicious, glomus tumor. Then this lesion, when you do IHC, that is more muscle actin positive, because this is a true cells we call parasite. Parasite is the small muscle originated cell try to hugging around the vessel. They are regular normal function just to regular your blood supplies in the extremity. When in the cold weather, they will try to shrink the blood vessel and try to make sure our other organ had enough blood supply. So this is the function of the glomus cell. This is another example of glomus tumor. Again, we know that it's well demarcated lesion, and even low power, we know a lot of blood vessel inside. Even we can see some red blood cell. And then the other component is the glomus cell. They look really monotonous, round. You may also thinking, is it just lymphocytes? But you zoom in, you can see all the cells look monotonous, and then they just try to trickling around the blood vessel. When you see the blood vessel go out, this cell also going out, so that is really characteristic for a glomus tumor. Let's see one more sample. This one is bigger, maybe in deep soft tissue. This one seems in the kidney. We can see glomeruli, but we can still see the same process here. All these monotonous blue cell try to surround the blood vessel. See, all of these cells are monotonous. So this is another example of glomus tumor. Okay, next case. This one is infantile hemangioma. Usually we rarely get the biopsy sample of this type of lesion because from the history, the clinician usually know that it's infantile hemangioma. So for the clinical pathology finding, just like this lesion happen in the first few weeks of an infant, and they usually spontaneously involution. So that means for this hemangioma, when you biopsy, you may have two phases. The first phase is the proliferating phase. So you can see this aggregation, lobular aggregation of these tight packed vessel together, and then this collagen bundle just separates this nodule. In the proliferating phase, you may see mitosis, but this is still benign because you may have a really good clinical history. This lesion from an infant. And then the cells are really monotonous. You do not see really hyperchromasia cell there. Then combine all the history, and then this endothelial vascular lesion, you can call this infantile hemangioma. And then characteristic IHC staining is grade 1. So individual nodule like this. And then the other vascular lesion hemangioma is called the Pyogenic Granuloma, aka Lobular Capillary Hemangioma. The growth picture just like this ectophilic, really red vascular rich nodule, usually in the distal extremity and even in the lip, in the head and neck area. This is another sample, this vascular nodule. The microscopic feature, if you call this pyogenic granuloma, you may not remember what it is, but if you call it lobular capillary hemangioma, you can see all of these features. Lobular, all of these endothelial cells, this vessel forming this lobular, 1 lobular, 2 lobular, 3 lobular. Then capillary means most of the vessels should be small, thin wall vessel, and then usually you will see one big vessel and then a lot of this small vessel just around it, just like this small vessel try to fit this big vessel. Big vessel, small vessel around, forming this lobular. This one also again, big vessel, small vessel around. Let's look at the cytology feature. They are really bland. Sometimes if irritated, traumatized, you may see tons of inflammatory cell, but that is normal. We also thinking this is not a true tumor, more like a reactive lesion, just like you get traumatized and then this lesion get more supply, blood supply, so they get this reactive proliferation of this small vessel. So this one is pyogenic granuloma. Another example of pyogenic granuloma, lobular capillary feature. Even in low power, we know this nodule kind of extrophytic because this is a normal epidermis, just a nodule growing out with this lobular structure, big vessel in the middle, and then small capillary vessel around. You can see they sometimes have these edematous stroma. Let's zoom in. Sometimes you may see tons of inflammatory cells, just like this lymphocyte. Sometimes you will see neutrophil, even eosinophil. That is normal. So pyogenic granuloma. Let's see one more case. This one may be still like nodular extrophytic growth. Even in this low power, we can see they're forming kind of lobular and then small vessel. Again, this kind of edema stroma also characteristic. Let's zoom in to see the cytology feature. This one we can see tons of inflammatory cell. This is neutrophil. Tons of blood vessel trying to fit in some larger dilated vessel, pyogenic granuloma. For the next case, this cavernous hemangioma, the growth picture just like this plaque-like vascular lesion, also in the young age. The characteristic feature, just like we can see tons of these dilated vessel filled with red blood cell, and then they aggregate to forming this kind of hemangioma, and then the cell is really bland looking. They do not have infiltrate border. They just like pushing around the surrounding tissue or even merge in the normal tissue. You can see fat, subcutaneous fat, acquired gland, and small vessel around. So this cavernous hemangioma. This is another cavernous hemangioma. Even this one is a relatively big lesion. We can see tons of red blood cells inside this dilated vessel, and then all these dilated vessels trying to forming this hemangioma, tumor-like lesion, but totally benign. Make sure to check the cytology. You do not see hyperchromatic, really atypical cell, and usually you do not find mitosis. Let's see the next one. This one is Masson tumor, aka papillary endothelial hyperplasia. This is another reactive lesion, but you can see in this dermoscopy, we can see this vascular lesion, tons of dilated big vessel with this thrombi. Actually, this is a truly reactive hemangioma. Even we have a name Masson tumor. The pathophysiology changes is like we have a big dilated vessel get thrombi, and then all the endothelial cell just try to grow inside this thrombi to get recalculation. That means this endothelial cell, because of lack of oxygen, so they try to proliferate to get more blood to fit the whole lesion. So when this endothelial cell grows inside this thrombi, you can see this papillary structure, but this is truly benign because you can see all the endothelial cell proliferation, just like bland looking endothelial cell. And then a good feature is that you see a big dilated vessel, and then all of these papillary structure just grow inside. They don't have infiltrated border, so that's a really good sign for this papillary endothelial hyperplasia, Masson tumor. See this papillary structure, but just recalculation of a big thrombi in a big vessel. For this one also the same, really big vessel, just get a big thrombi, this fibrin deposition. Then this endothelial cell just try to grow inside to dissect this big thrombi and forming this papillary structure. This is another Masson tumor, papillary endothelial hyperplasia. Also, we can see big vessel get thrombi, and then all of these papillary structure just grow inside. You won't see any this papillary structure growth outside. Of course, if you go to high power, you may see some, oh, maybe this is hyperchromatic, suspicious for angiosarcoma. But when you see the overall architecture, just like everything grows just inside this big vessel, no infiltrated border. Just like this one, you can clearly see all the papillary structure just inside this blood vessel, didn't go out. High power, this we see this papillary structure. We also see a lot of red blood cell. So this is just a reactive process. Intravascular papillary hyperplasia. We have another lesion, another nodule growth, usually in the extremity. And then history, you will find immunocompromised HIV patient. And then there are different stages for this lesion. This is Kaposi sarcoma. Different stage. This is forming a nodular tumor stage of Kaposi. So low power, you know, this is endophytic nodule, really bloody, because even in this power, we can see tons of red blood cell inside. When you zoom higher, you can see all of this lesion tumor cell are spindle cell forming this slit-like space. So when you see a nodule with really busy looking proliferation of spindle cell with tons of extravasated red blood cell, spindle cell proliferation with this slit-like space, you need to always bear in your mind whether it is Kaposi sarcoma. Of course, we have really nice immunostaining HHV8 to help you to define this lesion. Sometimes you can see inflammatory cell because, as you can see, as this nodule, they have an ulcerated surface. Every time under an ulcer, you may see reactive inflammatory cell. That is normal. So please do not let this lesion trigger you just like reactive. When you see these tons of proliferative spindle cell with slit-like structure. So this is nodular or tumor stage Kaposi sarcoma. Let's see more example of Kaposi sarcoma. This is a different stage, like a plaque stage. So you do not see a really distinct tumor nodule. However, even in low power, you can see this slit-like structure, a little bit red blood cell extravasation. When you zoom in, you can see this slit-like structure with this endothelial cell, kind of interstitious growth, almost dissect the collagen bundle. But why I want to show you this lesion, because we have one slam down feature of Kaposi sarcoma. This is this feature. You can see this is a endothelial cell forming this blood vessel, and inside the blood vessel there is a blood vessel growth inside. This is called pulmonary site. This is characteristic for Kaposi sarcoma. If you see this, you're almost sure this is Kaposi sarcoma. See another pulmonary site. This example is really classic. A vessel and then a vessel endothelial cells try to grow inside a vessel. Pulmonary site. That is really characteristic for Kaposi sarcoma. And then another feature, maybe this one is not really good. If you see acri gland and then some spindle cell try to hugging the acri gland, infiltrate in the acri gland, that is another characteristic feature for Kaposi sarcoma. And then you can do your HHV8 staining. This is another Kaposi sarcoma, just spindle cell proliferation forming this nodule in the dermis. We can see slit-like structure, extravasated red blood cell, spindle cell proliferation. So when you see all of these features, you highly suspicious for Kaposi sarcoma. As a contrast, you may hear one entity called the Infantile Hemangioma. This one is totally different from the Kaposi sarcoma, and then usually occurs in the axillary or the groin area. You can see kind of infiltrated growth. This kind is a borderline hemangio, because this one is called hemangioendothelioma. when everything called hemangioendothelioma, there's at least a borderline tumor. So the characteristic feature you may sometimes maybe really difficult to tell the difference between Kaposi sarcoma if you don't pay attention to some small changes. Like if you just see this area, oh, you can see this spindle cell just proliferate, forming this nodule, highly suspicious for Kaposi sarcoma. But when you see this dilated channel is not blood vessel. When you do the staining, it is positive for D240 because this dilated lymphatic channel. So usually in Kaposiform hemangioendothelioma, you may see this dilated lymphoid channel, not the blood vessel. That is characteristic for Kaposiform hemangioendothelioma. But if this lesion it occurs in the endo organ, it may kind of consume your platelet, and then it will cause some Casabat-Merritt phenomenon that will consume your platelets, and then really dangerous to the patient, because you can see if you have low platelets, and it will also cause kind of bleeding disorder because of this lesion. And then I also find another as a contrast for differential diagnosis. This one is ALHE, angiolymphoid hyperplasia with eosinophil, aka epithelioid hemangioma. So you can see this proliferation of this red ridge of blood vessel nodule usually happen in the head and neck area. As the name you already know, eosinophil. So for a classic lesion, it's kind of a dermal nodule. And even in low power, you can see tons of inflammatory cells, almost forming a germinal center. If you can see truly germinal center, there's another disease called Chimera disease. The microscopic features are identical to ALHE. But when you zoom in, other than this lymphocyte proliferation, you usually will see tons of these cells, eosinophil, tons of eosinophil inside. So you may just thinking, oh, could it be ALHE? And then you need to find other feature. In ALHE, usually also see a big vessel, and then around the big vessel, not like pyogenic granuloma, you can see tons of this spindle endothelial cell proliferation. But the blood channel, because this endothelial cell just really poor differentiated, they just could not forming I could not say really poor differentiated. It just like it's not mature endothelial cell. They just could not forming a blood vessel with a lumen you can recognize. But if you see the detail, you can see they still trying to forming a lumen around. And then this endothelial cell kind of plump. They kind of bigger, fatty plump than the normal endothelial cell. Just like all the blood vessel lumen kind of compact together. You just could not find the lumen. So when you see this big blood vessel lumen, eosinophil, and then around you can see this spindle cell proliferation, they try hard to forming a lumen, but just get kind of gets squeezed by other collagen or other structure around. They just could not have a mature blood vessel. That is ALHE, aka epithelioid hemangioma. So inflammatory cell, big vessel, and then the small slit-like vessel around. This is another ALHE. Low power, you can see tons of inflammatory cell, at least lymphocytes in this lesion, and then some blood vessel. Then when you zoom in, not only the blood vessel causes red, tons of eosinophil. See, in this area, so many eosinophil. When you see this eosinophil, you just would like to thinking this ALHE, and then find a big dilated blood vessel, and then find some vessel around. They're trying to forming this lumen, but they are just really good at their job, kind of immature proliferation of this endothelial cell. See, and then the endothelial cell cytology kind of plumps. They looks bigger, not like the regular endothelial cell. So this case is really classic. Big vessel, small vessel, try to forming this small vessel lumen, but they are not really good. And then with this plump endothelial cell, tons of eosinophil. This is another one. I think this one from the path presenter, they call it ALHE, but when you see tons of these germinal center, also suspicious for Camera disease. But as I say, usually the histology findings are really identical. Maybe we need some clinical picture. So let's zoom in to find our friends, tons of eosinophil. Everywhere is red. And then kind of a big vessel. And then surround the big vessel, we have this plump endothelial cell proliferation everywhere. Endothelial cell proliferation and look plump. The cytology, ALHE. And then whenever you see this big, widely excisional sample, you can kind of cheat it. It should be malignancy. If not malignancy, usually you won't get this big chunk of excisional sample. Then you can see big hair follicle go down deep into the subcutaneous. So it should be from the scalp. Then tons of solar elastosis. That means this should be an older patient. Tons of inflammation around. Look at this slit-like structure everywhere. Then we just zoom in to see tons of this blood channel lying with endothelial cell, but this is not endothelial cell. Look, the nucleus is really dark, almost like a lymphocyte, but they are really big compared to this red blood cell. There's really big cell, really scant cytoplasm, really high NZ ratio, really atypical looking of this cell proliferation, really infiltrated, really broad and deep, even go to the subQ. See, all of these are angiosarcoma, really infiltrated into a subcutaneous, and then they're forming this light structure to just dissect this collagen. That is the characteristic feature for angiosarcoma. Another case for angiosarcoma, also from the scalp, we can see hair follicle go down into the subcutaneous fat. Then we can see infiltrated border, tons of inflammation, reaction inflammation, and bloody. Let's see one characteristic feature, just this endothelial cell just dissect the collagen bundle to forming this almost like papillary structure. I think you still remember when I'm talking about the papillary endothelial hyperplasia, but during that lesion, you will find all this structure just inside a big lumen of a thrombi vessel. But this one, they just infiltrated everywhere. And then the cell is really dark, hyperchromatic, atypical, polymorphic cell. Then you know this should be a angiosarcoma. And then regarding immunohistochemistry staining, we already know we need to use classic blood endothelial marker. We usually use CD31. That is the cytoplasmic staining, a membrane staining, and then you can also use ERG. These two markers is really sensitive for endothelial cell. Some people may also use CD34, but I just would like to bear in mind CD34 may be negative in epithelial angiosarcoma. So CD34 negative could not rule out angiosarcoma. You must use your endothelial cell specific and sensitivity marker CD31 and ERG to highlight this lesion. If this lesion is related, like happened in the breast after irradiation, maybe in the head and neck tumor, the patient get irradiation and you get angiosarcoma, you can use CMYC to highlight this post-radiation angiosarcoma, and then you maybe you can for sure to tell the diagnosis. But if not related to irradiation, CMYC will be negative. And you need to also really cautious if you have a maybe look like vascular lesion but not really classic for angiosarcoma, and when you do the immunostaining CD31 negative, ERG positive, you would like to call this angiosarcoma, you need to really cautious, because I happen to have a case that is myeloid sarcoma. For this myeloid neoplasm, they may have ERG positive. So always not to rely on one marker to make your diagnosis. This is another angiosarcoma. For this excision or maybe a deep punch, you can see all the dermis just infiltrated by tumor cell. You know, when you see this infiltrated growth, really dark dim, even into the subcutaneous, everywhere, highly suspicious for malignancy. Even low power, we can see this cell is really hypercellular, really busy looking infiltration of the dermis. And then we can see this slick-like structure. You may think, what's going on? Is it artifact or true vascular channel? But away from this area, to see this classic area, what do you see here? You can see this really dark nuclear, hyperchromatic cells, endothelial cell, try to forming this blood channel, and then this endothelial cell also dissect this collagen bundle to forming this like wrapping structure, like a papillary structure that is really characteristic for angiosarcoma. The cell is really atypical, some are big, some are small, but really high NC ratio. We can also see prominent nucleoli, kind of epithelial looking. Some epithelial angiosarcoma, they may also CK positive, so you need to be careful. When you do CD31 ERG, they should be strong positive. See, they're going really dark dim into the subcutaneous fat, forming this and dissect this collagen bundle, forming this characteristic structure. So this is another really nice classic angiosarcoma.